Hello people, my name is Dr. Shabaz Ansari and as of right now I am an ex-clinical fellow who used to work in Glenclwyd, North Wales, and this is me winding up from North Wales, and hopefully I'll be moving to Manchester. And I just wanted to share my experiences of these 15-16 month of beautiful journey where I rotated from accident emergency to gastro to intensive care finally, and now this is the time to start a new chapter in my life, which I always wanted to pursue, which is surgery. And I am expected to join Manchester Royal Infirmary by 15th of February. So I just wanted to tell you and reflect upon what have I learned in these 15-16 months, and what have I done, what could I have done better. So I'm just going to sum this video up in a nutshell. I intend to make a detailed video if you guys want me to, but to be fair, this is just a note to myself. This is just a video diary that I want to keep, that considering this is my first job, I've had an amazing journey. I meet a lot of friends. I did learn how the NHS works in a holistic manner, starting from the A&E, and how are the cases referred to medicine, and how does a medical clinical professional picks up on the scattered pieces by the accident emergency, and what is the escalation pathway when it comes to intensive care. Let's start with accident emergency, which is by far my most favorite rotation out of the three, and it was also my first rotation when I started this job. I rotated in accident emergency for nearly 6 months, and whenever I got time or whenever I had the opportunity to do locums, I always used to prefer accident emergency as my locum department, and it became my second home. So I'll just explain how the accident emergency in the UK works. So in a nutshell, the accident emergency is divided into four parts. Number one is walk-in patients, which used to be GP out of hours, but after the COVID scenario, it has become just walk-in emergencies, where the patients are relatively stable and they can walk in and tell the complaints, and they can be discharged from then and there. And these are the patients who can wait in the waiting room, and for most of the time these are fairly the stable most patients in the hospital. And then we have got minors, where the minor injuries are these are the patients which cannot wait in the waiting room, or have been waiting in the waiting room for long, or they need some monitoring, not too invasive. And then we've got majors, where a little more sick patients are situated, who undergo maybe cardiac monitoring, or the nurses are a little more vigilant about them, and the nurses to patient ratio is better. And then we've got resus, where the sick most patients are situated, be it cardiac arrests, be it trauma calls, be it any seizure activity, any collapse. So the sick most patients are in the resus department, and we are covered as an F1, F2 registrars, and a consultant is always on board in order to support you. It depends upon the shift. You could have one or maybe two consultants covering, and it is quite a well supported department. And if you ask me, from my 15-16 month of experience, I would highly recommend to start as a clinical fellow in the accident emergency itself, because it gives you a holistic view of the NHS. How does it work? Because emergency department is actually the gateway of the hospital, and there you can interact with every speciality, be it surgery, be it medicine, be it oncology, be it ENT, anything and everything, and you get the taste of everything, and then you can pick your poison, and if I can say it plainly. And another thing, if you see, you always have the opportunity to pick up locums. This is a cheeky way to say it, but I can't really honeycoat it anymore. If you have got emergency experience, you would never run out of locums. It doesn't matter which department you work in. If you've got emergency experience in the UK, you can do locums, and trust me, locums are always available in the emergency. It doesn't matter what time you want, it's always going to be available. So yeah, but it is hectic, and people may or may not like the pressure of handling the patient flow, but yeah, I enjoyed it. I loved the accident emergency. My second rotation was gastroenterology, where I did my 6 months in gastro ward, but I used to do on calls and night shifts of general medicine. On the ward, you are basically responsible for the ward patients, and it doesn't really matter that if it's a gastro ward, you will only have gastro patients. You can have any patients as far as they are medically concerned, but the preference will be given to gastro patients to be admitted in a gastro ward. But you can actually get anything from chest infections, from sepsis, be it of any other source, but preferentially gastro patient, where you manage all the gastroenterology issues, upper GI bleeds, cirrhosis, manage ascites, and along with that the other medical problems. And you're very well supported because you've got an amazing staff. It comprises same goes as the accident emergency, F1, F2, registrar, along with consultants, and you make a plan in the morning, do your own rounds. After that, the consultant is going to do a round with you, and he's going to advise or recommend a couple of things, and you can always discuss or agree or disagree with the management plan with a consultant, and then make that plan into action, be it taking bloods or writing charts or clerical work, and then interpreting blood results and whichever things comes into it. And when it comes to on calls, so you are responsible to take patients over from the medical department along with the GP, whoever refers you the patient, and you've got an on-call medical bleep. One bleep is situated in the emergency, and one is for the inpatient doctor. So which one you are taking, you'll be responsible for that cadre of patients, and you basically pick up on the things which accident emergency has left, and they've stabilized the patient, and now you have to make a further plan whether this patient needs an imminent admission or whether this patient just needs to be surveillance, and you can book in an outpatient appointment, or a scan can be done, and if the scan's okay, you can discharge them with appropriate medication. And the patient who are admitted and they are not stable enough to be moved to an actual ward, they are situated in an AMU, which is an acute medical unit, where they are furthermore stabilized, and then they can be transferred into their parent ward. It can be gastro, it can be respiratory, it can be endo, whichever ward. Yeah, and you're very well supported in this department as well, because for example, so the thing works as in patient A has been referred from emergency to the on-call doctor. The on-call doctor is going to clerk it, and another doctor is going to post-take it, and the consultant is going to round with you, and then they're going to have a chat with the patient, review your notes, and see everything in a broader spectrum, and they're going to make a management plan whether this patient needs to come in or he can be discharged. And this is the gist of it, and I can make a detailed video on this as well, but in a nutshell, it's also a fun thing, but medicine is very hectic, and you have to be resilient to be a medic. And honestly, I've had my fair share of medicine, and I hopefully would not like to do a medical job, but I can make a detailed video if you guys want me to. My last and final rotation was intensive care, where I rotated for nearly 4.5 to 5 months, and it's actually a very different world from the other departments. And if you see it, it's actually step 3 from A&E to medicine, and then intensive care, which has got the sickmost patient of the whole hospital. Along with it, they get referrals for the patients who might need escalation plans at an early point, because there's no point in actually calling the ITU when the patient is very critical. So there are signs and symptoms which you see that this patient might need intensive care input. Could be because of cardiovascular support, could be due to vasopressor support, could be respiratory support, anything, or hemofiltration. So they can be referred directly from the ED as well, and A&E along with medicine. Both of them have got the authority to talk to an ITU clinical fellow who can assess the patient and come with a fresh pair of eyes. They might just advise, put the patient on surveillance by the other colleagues. Along with it, they also have to see the patient in a holistic view, not just the current medical condition. They have to see the social background, the functional background, the baseline of the patient, because you need to have something in order to survive the intensive care admission as well. Along with it, they're also responsible to attend all the med calls. The patient who imminently gets sick on the ward, suddenly collapse on the ward, or get high news. Along with you are responsible to attend all the cardiac arrests in the hospital, because if the patient achieves ROSC, they need to be in the intensive care to undergo a cardiac arrest, a post-cardiac arrest bundle, and the prognosis needs to be assessed in a controlled manner. So yeah, this is just a nutshell view of intensive care, and if you guys would want, I'm happy to make a detailed video upon it. And ITU is also very well supported. It's essentially a consultant-led specialty, because the patients are very sick, so they need the senior most input for every small decision, unless you are competent enough to make it without a consultant's advice. More power to you. And along with, you also get to do fancy invasive monitoring procedures, be it arterial lines, CVPs, dialysis line, along with intubation and ventilation as well. So this is my summary of the 3 rotations that I've been through. It has been an amazing journey so far. And if you have got any questions, please feel free to ask, and any comments or compliments as well are highly appreciated. And let me know how you feel about this video. Till then, see you later. Bye bye.